What about a patient with recently diagnosed diabetes and this new rash, as well as an abdominal mass? I've covered this in my other reviews, but you need to know that this is necrolytic migratory erythema due to glucagonoma. And these patients get a surgical excision of the pancreatic mass. 26. What is your diagnosis? You should be thinking pseudopelgar-Hewitt cells. This is seen with myelodysplastic syndromes. Your next best step is a bone marrow biopsy to confirm. If you see these bilobed nuclei here, you're thinking pseudopelgar-Hewitt cells. It's usually an elderly patient. 27. If a patient has cirrhosis with new onset decreased right lower lobe breath sounds, what's your diagnosis? Here's your chest x-ray. This is crazy high yield. You're thinking hepatic hydrothorax. The treatment here is salt restriction and diuretics to help diurese some of that fluid out. It's a huge pleural effusion here from the hepatic hydrothorax. 28. If a patient has femoroacetabular impingement, what's that also known as? It's called Federer syndrome, and that's going to be hip pain that's worse with flexion, adduction, and internal rotation. And the diagnosis of choice here is going to be an x-ray, which will show cam and pincer lesions. So they'll give you these two views of the x-ray on the test. If you see these cam and pincer lesions here, then you know that you're dealing with femoroacetabular impingement. 29. If a patient has HSV blepharitis, how do you treat it? Well, you want to obviously treat the herpes virus with acyclovir, valacyclovir, or famciclovir. And recall that if patient has an active HSV infection during pregnancy at term, then you want to do a C-section. That's something they love for the OBGYN shelf. Some high-yield associations is if they have odynophagia without dysphagia plus intranuclear Cowdrey type A inclusion bodies. You're thinking herpes simplex virus infection. You're not going to see these intranuclear Cowdrey type A inclusion bodies tested otherwise. They're always with HSV on your boards for the USMLE. What is this? So let's say that a patient had an iatrogenic left subclavian artery transection and their chest tube is putting out all of this milky fluid. Your diagnosis should be chylothorax. And so remember, chylothorax will present with high lipid count. Your triglycerides will be over 110, as well as an exudative pleural effusion due to a thoracic duct injury. And so the subclavian artery is very close to the thoracic duct, so that's why that's the clue here. It could be from some surgery, they're repairing the subclavian artery, and maybe they get into the thoracic duct and they have all this milky fluid draining out of their incision. Or maybe they have a pleural effusion with all this milky fluid. These are ways that thoracic duct injuries can present. And so let's go through some etiologies of milky pleural effusions. So chylothorax, like we said, will have elevated triglycerides over 110, but so will a cholesterol effusion. And so the big thing to look at is the fat globules. If there's positive fat globules, you're thinking chylothorax. If there's no fat globules, you're thinking cholesterol effusion. And so if it's a low output pleural effusion, if it's less than 1 liter per day, you can give them a medium chain fatty acid diet. You can do parenteral nutrition and octreotide, and if that fails, you can do surgical interventions such as embolization. And then for a high output pleural effusion that's milky, you can go in and ligate the thoracic duct or embolize it, because it's not going to just resolve with dietary improvement. The thing you have to know for your boards, though, is the first step is putting the patient on a medium chain fatty acid diet. That is tested ad nauseum. 31. If you see this lesion in the patient's pelvis here, you're thinking chondrosarcoma. And so see how all the surrounding tissue here is calcified. It's a destructive invasive lesion with calcification of the surrounding tissues. What is this? So you see a patient's eye and they have this white spot. Maybe they're complaining of some night blindness. Well, that's a bitot spot, and it's due to keratin buildup in the conjunctiva. This patient has vitamin A deficiency, and that's why they have the night blindness. So your treatment is just replace what they don't have, which would be vitamin A. All right, again, I wanted to throw this back at you guys because this rash, this necrolytic migratory erythema can present a bunch of different ways. These patients will usually have the 5 Ds. So they have diabetes, DVTs, dermatitis, depression, and declining weight. And so if they have no history of immobility, no known hypercoagulable disorder, and they have this rash, you should really be thinking necrolytic migratory erythema that is seen with a glucagonoma. If you check their labs, they'll have a random glucose level of over 300. And to diagnose this, you can do a CT with contrast or an MRI of the abdomen, And treat it is going to be octreotide to manage the glucagon levels as well as surgical excision. All right, and then one more time. Here's a review, another crazy high yield image. You see these Gotrin papules. What's your diagnosis? Well, you're thinking dermatomyositis. The reason I'm testing you guys on these concepts over and over again is because these things show up and students miss them every single year. Dermatomyositis is also associated with the Gotrin sign. So know the difference between Gotrin papules and the Gotrin sign. The sign is on the extensor surfaces. And then you have the shawl sign, which is a rash on the chest and shoulders. All right, and then one more time here, you see this diffuse erythroderma with pruritus and lymphadenopathy. What's your diagnosis? You're thinking Sézary syndrome. Remember, you'll have those cerebriform nuclei. And the key here is that there is no timing of the pruritus, aka it's not related to showering like polycythemia vera. Polycythemia can have aquagenic pruritus, whereas Sézary syndrome can have the pruritus at any point in time. And so to diagnose, like we said, their blood will show cerebriform nuclei. You have to be able to see this and diagnose it. All right, what about these lesions right here? So they're itchy lesions on a child after a sleepaway camp that appeared one morning. You're thinking bedbug bites. And so this is going to be due to Simex leticularis. And so you have to be able to know the bug that causes it as well as what you should do next. And to treat it, you would want to sterilize the bedding. So you can supportive treat, but the big thing that the boards will want to know is sterilize the bedding, put them in an airtight sealed compartment, wash that, and then that will help get rid of the bed bugs. This is one that is an interesting concept here. So you see a rigid kyphosis in your patient, and they have wedge-shaped vertebrae, and this is known as a Scheuermann disease. And so these are Schmorer nodes, which are vertebral disc herniations through the nucleus pulposus. So that's a Schmorer node. 38. If you see a patient with avascular necrosis of the femur, your diagnosis should be in a young patient, leg calf Perthes disease. And this is going to usually be a male that's age 4 to 12 years old. Their symptoms will be that they walk with a limp, and sometimes it's painful, sometimes it's not. But you see this avascular necrosis of the femoral head here. And these patients, they will more often than not in real life present with a limp with pain, but in the clinic on the boards, they may not, just to make it a little bit more tricky. And so the treatment here is orthopedic splinting and decreased weight bearing. And your differential is SCFE, slipped capital femoral epiphysis. And this is usually going to be an obese 10 to 15-year-old. So if it's a little bit older child that's obese, you're thinking SCFE. If it's a younger patient that doesn't mention obesity, you're going to be going with leg calf Perthes on your differential. And so these are just test taking tips here. Obviously in real life, it can be multiple different things, but this is how you navigate the boards. All right, what about if you see this on EGD? These patients have simple columnar epithelium with goblet cells, and it's changed from normal stratified squamous epithelium. Well, you should be thinking Barrett esophagus. The key thing here is knowing your histology, and you can tie that to your image. So that's how you get the Barrett esophagus.